Check.
Check. Hello. Wonderful. Hello. Beautiful.
Testing.
This one does not fit in there. Okay.
Because Hello. Volume on. Volume. Program. Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. Can we kindly take our seats so we can start with our program? Is that with who? I pressed it somewhere.
You just sent my email. Subject to the computer. Email would be better.
Okay, I have this email. Yeah. Good morning, ladies and gentlemen. Let us kindly take our seats and start with our program. Yes, once again, good morning, ladies and gentlemen, those physically present with us here and those online. Thank you for honoring our invite to this dissemination meeting today. My name is Melody Kukundakwe, the Communications Officer for PMA Uganda. I'll be your moderator for that day, alongside Ms. Harriet Adong from the Resilient Africa Network. I would request all of us to stand up for an opening prayer, and thereafter we'll have the anthems to honor our country, East Africa, and Makerere University. Before the anthems, I would request Ms. Harriet Adong to lead us in a prayer.
Thank you, Melody. Let's humble ourselves for a word of prayer. Lord, we thank you for the gift of life. We thank you for today. We thank you for keeping us up to now. We thank you that we are together this morning. We thank you for PMA, for the School of Public Health, for Makerere University, and all our implementing partners. We pray that you come amidst us as we deliberate. May it be for the greater glory of your name, but also for the greater glory of our institutions, the country at large, and the globe. I pray, Father, that you guide our discussions, that all might go successfully. I pray all this with thanksgiving, believing in Jesus Christ our Lord. Amen.
Thank you so much, Harriet. The anthems.
Oh, Uganda, Mashariki, tuwezeshe kuishi kwa amani, tutimize na malengo yetu. Jumuiya yetu sote tuilinde, tuajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu. Uzalendo pia mshikamano viwe msingi wa umoja wetu, na tulinde uhuru na amani, mila zetu na desturi zetu. Jumuiya yetu sote tuilinde, tuajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu. Viwandani na hata mashambani, tufanye kazi sote kwa makini, tujitoe kwa hali na mali, tuijenge jumuiya bora. Jumuiya yetu sote tuilinde, tuajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu. Makerere, we build for the future, the great Makerere. Great, great and mighty, the walls around thee. Great, great and mighty, the gates beside thee. Great, great and mighty, the walls around thee. Great, great and mighty, the gates beside thee. From east and west, from north and south, all voices singing, arise, Makerere. Rise up and rise, high up and great and mighty, the walls around thee. Great, great and mighty, the gates beside thee. Do not forget, through all the years, those who have gone through the gates of Makerere. Give them the pride, give them the joy, all to remember the gates of Makerere. Makerere, Makerere, we build for the future, the great Makerere. Great, great and mighty, the walls around thee. Great, great and mighty, the gates beside thee. Great, great and mighty, the walls around thee. Great, great and mighty, the gates beside thee. Those who hear be, seek ye the truth. Build for the future, the great Makerere. Those who have been, those who will be, build for the future, the great Makerere. Makerere, Makerere, we build for the future, the great Makerere. Great, great and mighty, the walls around thee. Great, great and mighty, the gates beside thee. Great, great and mighty, the walls around thee. Great, great and mighty, the gates beside thee.
Thank you so much. We can all take our seats. In a special way, I want to recognize our donors, the Bill and Melinda Gates Foundation and the Children's Investment Fund Foundation. I would also like to recognize our project management unit, JAPAIGO, and our technical unit, the Johns Hopkins University, all Ministry of Health, and all implementing partners. I'll now request Ms. Harriet Adong, our co-moderator, to welcome our chairperson for today.
Thank you, Melody. I thought Melody deserved a hand clap. Is it because we've had breakfast? Thank you. Ladies and gentlemen, allow me to welcome our chairperson for the session. And briefly, he's one of us. He's Dr. Mugahi Richard, who is our Assistant Commissioner for Reproductive and Infant Health at the Ministry of Health in Uganda. He was formerly a district health officer for more than 10 years and also worked as a health service provider at different levels of healthcare. Dr. Mugahi is currently a member of the National Safe Motherhood Committee, and he has also worked as a board member of Dr. Mugahi to take us through the session this morning. Over to you, Doctor. Thank you.
Thank you so much, Harriet, for that very humbling introduction. My role really is to chair this very important function, and I would like to draw your attention to our program. The program sheet is right in your booklets, and I was just consulting, but allow me, before we go to the program, to recognize the presence of a few personalities amidst us. And if we had a second mic, it would be really appropriate for them to introduce themselves. These are very big people. In a special way, I would like to recognize our honorable members of parliament present here with us. If there's no extra mic, I think we shall do that later. I'm just careful not to miss out some, but I can see ably the chairperson of the Health Committee of Parliament, Honorable Charles Sayume. Thank you so much for coming. He's always been with us. Dr. Kamara. Dr. Kamara is a physician and also a vasectomy champion. I saw him waving at me when they talked about vasectomy. Dr. Kamara, thanks so much for coming. Honorable Sylvia, thank you so much for coming. She has been with us all through. The vice chair of the Health Committee of Parliament, I've seen him behind there. Thank you so much for coming, Honorable. I think my friend and colleague Francis and Charles will help me recognize the other members of Parliament. They could be within here, but may not be able to. Can we get a mic and they introduce themselves? I don't want to make mistakes very early in the morning. And sanitizer. Briefly, the members of Parliament, we appreciate your presence. Would like you to introduce yourself. I managed to introduce those who I could see.
Thank you very much, Chair, and all members present. I'm called Sylvia Bahireira Tumwekwase, a member of the Health Committee, and I represent the people of Kamwenge District in Parliament. Thank you.
Good morning, colleagues. I'm Dr. Nicholas Kamara. I'm a consultant physician, but I'm also member of parliament for Kavali Municipality, member of Health Committee, and chairman of Parliamentary Forum on Non-Communicable Diseases. Thank you.
Good morning, colleagues. My name is Dr. Charles Ayube, Member of Parliament, Koboko Municipality, and the Chairman of the Parliamentary Committee on Health. Thank you.
Chair.
This is, Dr. Mwonge, where you are seated there, I think you can become a member of parliament by infusion.
Thank you, Chair. Good morning, members. I'm Sebikali Joel, MP, Twetwe constituency, Chankwanzi district, and I'm the Deputy Chairperson, Health Committee, Parliament.
Thank you so much. Catherine, you can wave at us, and you've done a great job. You always help us. Catherine works with Parliament, and she always helps us. And Susan, I think. And Lydian, yeah, that's good enough. So that's the group from Parliament that we have with us. I also want to recognize the group from Makerere. Let's now recognize in form of groups, and we move. Group from Makerere, I think you wave for us, you wave at us. Most of you shall be seeing you. Honorable is again in another group of Makerere. The group from Ministry of Health, I can see Commissioner Penso, Commissioner for Community Health Services, and myself, Rogers, and the team. Thank you, Ministry of Health. Our partners, implementing partners, USID, I can see Rita, I can see PATH. Implementing partners were for us. Thank you so much. Religious leaders, implementing partners don't want to show themselves, but we are going to give you assignments in this meeting. Religious leaders, there is no pastor. You are the only one who doubles, triples. He's also a pastor. Thank you, Honorable. If there's any other category, the media, you are very important in family planning. NPC. And on that note, allow me also recognize my former chair at the National Medical Stores Board, who is also the director of NPC, Dr. Joseph Musenguzi. He's part of the agenda today. Dr. Joseph, you're most welcome. And thank you for having been the brain behind most of the family planning reforms in this country. Colleagues, that marks the end of the introductions. If there is a special group that I have missed out, Prof. Makumbi, have I missed out a special group? I guess no. Oh, our online, our virtual attendees, Dr. Laro Charles, Director, Curative Services, Ministry of Health. You're most welcome, and you'll make some remarks. Professor Roda, the Dean, Makerere University School of Public Health. You're most welcome, and we're expecting your remarks very shortly. Friends, allow me at this time to invite Professor Roda Wanyenza to make remarks on behalf of Makerere University, and then that will be followed by Dr. Charles Solaro. Professor Roda, you're most welcome. We missed your physical presence.
Thank you, Dr. Mugehi. I have missed you all as well, and but I'm still excited to connect with you all online. Our members of Parliament, the chairperson for the PMA Technical Advisory Group, Dr. Musenguzi, implementing partners, our religious leaders who are present here with us, colleagues from academia, the PMA team, the media, ladies and gentlemen, all of you in your respective capacities, a good morning. It's a great pleasure for me to connect with you this morning. As always, we look forward to engaging with you and to sharing with you what we do at the School of Public Health, because we believe that if we don't share with you and if we don't take decisions based on the evidence that we generate, then our research is not of any use. because we know that the primary reason why we generate this evidence is so that you can know where we are with our policies, with our programs, so that you can know where the challenges are. Who is it that we are leaving behind? We are now in the era where we believe that we are as strong as the weakest link around us, and that the more we are able to bring everybody else on board, the better we are, all of us together. So a lot of the work that we do is geared towards showing where we are, but especially showing who we are leaving behind, so that we can do better to bring everybody on board. And the PMA program is just one of those flagship programs at the School of Public Health, where we generate evidence and continuously engage with all of you, so that together we can decide what more we can do to better serve our people, because we don't improve programs for the sake of it. We don't make policies for the sake of it. We do that so that we can better serve our people, and that's what we desire to see. And this program shows this especially because all the data that we have generated has been used by all of you stakeholders here with us today. For example, we've just used the PMA data to inform Uganda's FP 2030 commitments. And before that, we were also looking at this data when we were developing the costed implementation plan. And for partners in the room, implementing partners, those that are coming from outside Kampala, how we can bet times we are doing well overall, but we are leaving some regions behind. So this is just an example of what we orient our public health systems in a holistic way, looking at all sectors and determinants of health. And I would like to especially draw your attention to education. I know you're members of the health committee, but you need to engage with the education committee as well, because we have so severely disrupted education that is going to hurt health for many years to come if we don't act today. And then we also need to be reorienting our health to look more at promotion of health and prevention of disease. Please don't focus at only treating people who are sick. So to our members of parliament, please look at these issues holistically, and we are available to engage with you more if you can give us space, so that together we can chat away in terms of how to improve the health of Ugandans in a holistic way. So with this, I would like to say that together we can also generate more evidence. You can tell us where is it that you need more evidence that you don't have, so that we can work together to generate this evidence. Now I know today is for family planning, so that's enough of the other public health, but I wanted to say that we are available and we are ready to work with you so that you can make more evidence-based interventions. To this occasion, I would like to thank all the partners that have worked with us for a very long time to make this work possible. We have worked for a long time with our partners from the Population Council. We thank you so much, Dr. Musenguzi and your team, Dr. Charles Solara and colleagues from the Ministry of Health. Thank you so much for continuing to work with us. The School of Public Health, JPIGO, the Uganda Bureau of Statistics, thank you so much for continuing to work with us on many surveys that we do in this country. But I also need to appreciate our teams. Dr. Makumbi Foundation, thank you so much for partnering with the School of Public Health, not only in this particular survey, but also in many other projects that we jointly implement together. And as we celebrate 100 years of Makerere University, on behalf of the university, I would like to pledge that we will continue to generate evidence that adds value, and that we shall not be in the ivory tower, as many people always ask us to do. You can see that for us at the School of Public Health, we are not in the ivory tower. Although some of us are speaking off Zoom, we are with you most of the time, and we value our interaction with you. So thank you so much, all of you, for taking your time to join us this morning. And I hope you will enjoy your stay with us I hope you leave, most importantly, with something that can add value to the work that you do to serve Ugandans, whether you're in Parliament, whether you're in the Population Council, in the Ministry of Health, implementing partners. Please do listen in and find something that can add value to the work you do so that we can better serve our people. Thank you so much.
Thank you, Professor Rhoda, and that clap is for you. We really appreciate your comments, especially the call for evidence-based interventions and the availability of the Ivory Tower to keep producing this evidence whenever we need it. We also appreciate your comment on the partnership with education, given the fact that the determinants of health, some of them are housed in education, others are housed in agriculture, and we need a total rethink of our post-pandemic public health interventions. Thank you so much, and we really appreciate all the great work that you continue to do for us. At this time, I want to report that our Director for Curative Services, Dr. Charles Olwaro, transitioned from virtual mode to physical mode. It must have been by God's grace. Miracles still happen. So Dr. Charles Olwaro, my old friend, we've known each other from a long time ago. We worked together in Fort Portal. Now we are together. He's my boss at the Ministry of Health. He's been a very great champion of family planning, reproductive health. He's also the chair of the National Experts Committee on Safe Motherhood. And he continues to support, like Rhoda mentioned, and he has managed to make it this morning. He has opening remarks to make. Dr. Charles Olwaro, kindly step forward and make your comments. Join
the chair of the Parliament, the Dean of Makerere University School of Public Health, Professor Rhoda Wanyensi, my chair of PMA Technical Advisory Group, Dr. Joseph Musenguzi, implementing partners, religious leaders, the academia, the PMA team, the media, ladies and gentlemen. As the chair has indicated, I've transitioned, now I'm here physically. I thought I would have been here much more early. My apologies for that. But also, as Professor has indicated, this is what technology allows us to do, so that you have no excuse that you cannot be able to join. So this morning, as a Minister of Health, this engagement is very important for us and very dear for us, that it forms another fulfilling one as we come together to share the National Performance Monitoring for Action Survey 2021 survey results. As you will hear, you'll agree that this is very helpful and very useful for Makerere University School of Public Health to conduct National Performance Monitoring for Action, the PMA surveys. We are grateful to Makerere because it's been able to contribute and be able to do this work. Otherwise, probably would be hiring a consultant to do that. So this is an inbuilt in-country capacity, and we're grateful for that. The data collected in these PMA surveys inform monitoring and assessing progress of the targets as we set in the FP 2030 commitments and the costed implementation plan. I'm happy that all of you were involved during the formulation and official launch of this commitment. I'm also happy to mention here that I sit in the FP 20 Global Committee, and as you know, this is great for both, not only for our country, but for the region. From the last PMA survey, we have seen the country is making progress. However slow it is towards increased modern contraceptive use. We have been able to monitor this new mode of delivery of Depo-Provera through the subgenus injection, Cyanopres, that has become very popular in the last three years. And as all of you know, the FP 2030 commitments were launched. So we need to be able to work. We'll soon be able to share with you also the costed implementation plan, which is really a precursor for us to be able to achieve our FP 2020.
We are now serving number.
I will work with my teams because I would have really wanted that each of the members in this room would have a pocket, a small pamphlet, which is really highlighting the 6 commitments which as a country have made, but also picking up. So Richard, I think this is some of the things which we need to be able to do it, so that members keep reminded of these commitments because they are very difficult to learn. However, there are challenges. Much as we have made progress in family planning delivery, there are still some unresolved challenges. For example, the PMA has shown over time that there are challenges with the quality of family planning services, especially regarding the counseling of users. And if you go to our commitments, actually one of the commitments is actually dedicated to address this specific challenge, to address family planning myths and misconceptions. And so government is committed to improve the quality of family planning counseling. And in counseling, definitely we provide what are the available options, the possible side effects, because we have to be true to it, there are some side effects, but how do we manage them, their management, and how does the user switch on the different components. So we think that if we shall be able, though it's a challenge, but with the implementation of the commitment, and if we're able to measure it well, we should be able to overcome it. So what's new in this dissemination? This year we have results on self-injection for subcutaneous injections. As you all know that when COVID came, we really tried to look at what are those innovation approaches which people can be able to use. And I must say that if mothers girls were able to access the self-injections, then you could be able to prevent many of the unwanted pregnancies. Because just to remind you, 4 out of 10 mothers who are pregnant did not intend to have those. So they are really kind of like unwanted pregnancies. Though they have no alternative to carry them up to the end, but they would have wanted to defer them to certain appropriate time. The year survey also helps to gauge the effects the COVID restrictions may have had on the contraceptives. So we'll be able to see that probably would have been at a different level, but COVID came in. Though we might not put all the excuses on COVID, but what was the effect of COVID on that? So I want to conclude by some free take-home messages that the current challenges in this area of study and discussion require a concerted efforts of Ministry of Health working with all of us in this room and even outside. And I hope the chair and the members, first of all, your attendance here is already sure that you have the commitment to be able to work with us in this aspect. We need to develop, adopt, and use innovative strategies to inform programming in an effort to address some, if not most, of these challenges. And I want to implore all of us to continue implementing what works based on the findings and creatively work to address the challenges that the surveys help us to unearth. So I would like to thank Makerere University School of Public Health, the Uganda Bureau of Statistics. I hope they are represented here. My colleagues at the Ministry of Health, all partners for this effort. I also want to thank the local as well as international partners, the Bill and Melinda Gates Institute of Population and Productive Health at the Johns Hopkins University, and JAPIGO for collaboratively working and supporting the generation of this data. And I think they deserve a clap. So Adong, as the communication officer, you'll communicate that we clap to appreciate all what they have said. So lastly, again, these statistics that guide in programming for family planning in this country. So we really need to be able to see that at every point in time we should be able to gauge where we moved. We should not wait for the end of, by 2030, we should be able to see what is that we're able to achieve at the end of 2022, and progressively we should be able to look at that. We are all looking forward to a continued good working relationship as we strive for a better lives for our communities in which we serve and we live, for God and my country. Thank you for listening. I don't know whether I heard properly when the chair mentioned that I was supposed to open. So I think at the end of those remarks, the meeting is officially open. Thank you very much.
Thank you. Thank you. Another big round of applause, Dr. Charles Solaro. Thank you so much. I had left out one of your titles. I thought you would mention it yourself. Dr. Charles Solaro is the focal point person for Uganda at the FP 2030 platform. I think they sit in Washington. Join me in thanking him for representing this country ably. I don't like paraphrasing some remarks, but he was very explicit in mentioning that we need to translate evidence into practice and policy, and we must implement what works. In the family planning arena, we all know we have the high impact practices. So that is probably what is awaiting us in the general remarks. Once again, thank you so much, Dr. Charles Solaro. Your request on the 6 pillars for the 6 points for the family planning commitments, even before we leave here, I think we should be able to print and each one of us goes away with them. That's very important about our strategic direction. According to the program, we now receive remarks from Uganda Bureau of Statistics, but I have requested my friend, Dr. Charles Sayume, to also make remarks on behalf of that constituency that is amidst us. Brief remarks, I know it's an ambush, but as a health professional, I know you'll have some comments about family planning. Some of you may not keep here till the end, but if we would hear from you, it would be very nice, our honorables. So Mr. Chris Mukizi is not here with us, but I would also like to welcome Mr. James Muwonge, who is representing Dr. Chris Mukiza from the Uganda Bureau of Statistics, to step forward and make his remarks. We are doing quite well. All the speakers have kept time. You're welcome. Join me in welcoming Mr. James Muwonge to make remarks.
Thank you, Chair. Honorable members of Parliament, Dr. Musenguzi, my Chair, implementing partners, colleagues, ladies and gentlemen, good morning. On behalf of the Bureau of Statistics, I would like to congratulate the School of Public Health, Professor Makumbi and team, for pulling this off again. I think there have been several surveys that have been undertaken. And to us as a Bureau, we've been working closely. And having consistent data for so many years is not a very common feature in many agencies. And to us, this is a clear testimony that the kind of competencies and skills in survey implementation are at the levels of best practices. So I just want to thank you. I think this is an area which initially started at a low level, but now when I look at the audience and the participants in this room, it really demonstrates the kind of attraction it has received and the importance you attach to the kind of information that is coming through. Of recent, it's not only looking at cross-sectional, but now they're even going further to even follow others were interviewed previously. So paneling and looking at the dynamics is another feature that this team has brought on board, which is quite important, and it will be able to provide you with even much more insights into collect all the information, but agencies and institutions, research institutions, continue to share information and share best practices. I think the key thing here is coordinating our efforts, research efforts, across the different agencies, and make sure that we are able to share information. I think the Dean of Makerere has talked about it, the need to utilize information. There's a lot of information that has been collected, but probably not so much is being used. But I'm at least looking at the audience here, I'm encouraged, and I feel a bit contented that the level of utilization is getting as far as the parliament. And to me, this is quite important, because information should influence policy and decision making. And the fact that in this audience we have those policy makers, to me it's a testimony that the value coming out of this survey is really quite important. So I would like to thank you once again, and they promise that as a bureau we'll continue working together, and probably also encourage you beyond family planning. You could also explore other areas, so that the expertise you have acquired in implementing these surveys also extend to other areas of disciplines, so that the best practices not only limited to this one, but also we see and get more information to inform policies, not only in Ministry of Health, but also in other areas. Because as they say, you see, health, there are so many other factors that contribute to health. So we need to look beyond health and also cover family planning is one, but there are other areas. So where data is still, there is a data gap. So we need to keep on closing these data gaps, so that our policymakers are well informed with what needs to be done, and they are equipped with evidence that we should be able to provide as a bureau, but also as the School of Public Health. So ladies and gentlemen, I just want to thank you and wish you good deliberations. I thank you.
Thank you so much once again, Ubos, for joining us this morning and for the words of commitment to continue working with us, and the challenge of talent. As I earlier mentioned, I've been briefed that in your folder there is a mask, and I think Harriet wanted us to be uniform. I don't know. She wanted us to be homogeneous for branding purposes. So, but you can remain heterogeneous. I think it's acceptable. But there is a mask for you in your pack, and it's branded PMA. The P is performance, M is monitoring, and A is action. It actually ushers us to the next session of this meeting, where Professor Makombi and Dr. Simon Chibira are in charge of PM, performance monitoring. Myself, Dr. Olaro, and other stakeholders for action. In Uganda, there is a tendency of choosing what we want to do. We can do performance monitoring and forget action. We have been engaged in the national MPDSR, so we usually say that the R is neglected, maternal and perinatal death review and response. So we don't do much of the response. We review and we forget to respond. So I don't want a scenario in PMA where we do performance monitoring and we forget action. And for this specific meeting, Dr. Betty Chadondo will synthesize the action bit. I've been briefed that he will take us through the A. Professor Makombi and Dr. Simon will take us through the PM, performance monitoring. And I'm very informed this is not the first time, it's not going to be the last. So they will always give us the performance monitoring, how we are doing, and how we use this is actually what measures our success. So I had earlier mentioned that I would kindly allow Dr. Charles Ayume to make some remarks. I've ambushed him, but I know he's good enough. The reason is really for constituency representation. They're usually busy people. They may not be with us till the end, but if you can make some remarks and listen in, we will be very happy to engage you in the discussion. Dr. Charles, you're welcome. Join me in welcoming him as he makes his welcome.
Thank you very much, Dr. Mugahi, and the very pleasant ambush, but we're always prepared for any eventualities. My colleagues from Parliament, especially from the Health Committee of Parliament, the Director of Clinical Services, Dr. Olaro, the various health partners with us in the room, members from Makerere University, led by Professor Makumbi and Dr. Chibira, who are also, I'm also a student. I hope these are not my political opponents. Trying to sabotage a wonderful speech. Yes, I was just saying I'm incidentally a student at Makerere University, so no doubt about the competence of the team led by Professor Makumbi. Ladies and gentlemen, you're most welcome, and mine is very simple. We are very happy as the Parliamentary Committee on Health to always be invited for these engagements. It really sharpens the way we articulate issues in Parliament. And I must say, we really want a Parliament that articulates issues based on evidence and very strong data, not one where we go and debate based on emotions and political sentiments. I think that is very dangerous for the direction of the country, where we are on the floor of Parliament just arguing and debating based on emotions and retrospective beliefs. So for us, it's very important that we're invited for such engagements where we come to listen to evidence and data, what's in the field and what are the best practices, so that when we go there, because we do not only represent our constituencies, our political constituencies. The health sector, like I keep on telling many people, is a constituency. So I have one foot in my political constituency, but I am also duty bound to represent the views of the health workers on the floor of Parliament. And good enough, I have other health workers here. Honorable Bahireira, she didn't tell you, she was worked in Kamwenge district and the Rwenzori area for a long time. She's a midwife. We have Dr. Kamara, he's a consultant from Kabale. We have Grania, she's a laboratory technologist, woman member of Parliament of Mubende, and so many other health workers on the committee. And of course, my vice, we are about to also bestow him the title Dr. Sevikali, because he has been there for a long time and he understands the sector. So we are very humbled, and we shall continue coming to listen to words of wisdom whenever we're invited, so that we can translate this, because this is where data is produced, but then policy fortunately or unfortunately is discussed on the floor of Parliament. So if you do not arm us well, then we do a poor job on the floor. So thank you very much for having us over, and we pledge total support where possible. Thank you.
Thank you so much, Dr. Charles Sayime, for those wonderful remarks. I think we would have missed them. Ladies and gentlemen, we are done with the component of remarks. I think we are now going for the muscle. And in that session, we are going to be led by Dr. Simon Chibira. I have known Simon for some time. He's a very committed academician. He's been taking us through this PMA. We've done a lot of good work in this. Simon is going to take us through the PMA 2021 survey, background and methodology. And kindly put your hands together to welcome Simon. Dr. Simon to make his presentation. Simon, you're welcome.
Thank you, Chair. Allow me to take this off because I'm going to speak for a while. Good morning, ladies and gentlemen. Thank you for the kind introduction, Chair. So I'm going to take you through part of the methodology and then part of the results, and then Professor Makumbi will take you through the other half of the results. This survey is conducted, as you've seen, by Makerere University School of Public Health, together with the Ministry of Health and the Johns Hopkins University School of Public Health, the Gates Institute for Population and Reproductive Health at the Johns Hopkins, and JAPAIGO, both in Baltimore and Uganda, and Mr. Andifuna is here today. So we have a lot of support from JAPAIGO in the country office, who have the program management unit here in the country. So quickly, slides. Okay. So this is the outline of the presentation today. We'll take you through the implementation of the 2021 survey. We've been conducting this since 2014. So this will be like the 9th time we are conducting this survey. And we'll take you through the findings from the household and the female survey part, and then the service delivery points survey. And also we have a special component, as you heard from Dr. Oralo in the morning. We are going to present to you a bit of patterns of DMPA-SC, or subcutaneous and self-injection that is associated with it today, because these were financed specifically by the Children's Investment Fund Foundation to try and monitor this, the training and also the continued scale-up of this. As of background, I've already introduced this, but this is conducted together with the Bureau of Statistics and the Ministry of Health and the Bill and Melinda Gates Institute for Population and Reproductive Health. And the funding, we've always had funding from the Bill and Melinda Gates Foundation, but today, this year's survey, we also have funding from the Children's Investment Fund Foundation, as I have introduced already. We want to start with acknowledgement. Usually people end with this. We want to start with this, very important. And we want to start with the population that provide this data, the household data. The respondents are the household heads, both male and female, and then the women who respond to the individual questionnaire, which we use to obtain all this data. We also have health facility in charges and people at the different points within the larger facilities like hospitals, because we interview people from different areas within the hospital. So those, we also thank them very, very much. And of course, at the smaller SDPs like drug shops in the communities, those are usually one provider. We also interview those. We thank them very much. The team is led by a technical advisory group from the, led by National Population Council Director General. And then all of you as implementing partners here, the media, thank you so much. And very importantly, when we go to the districts, we have entry from the district health offices and the whole leadership up to down to the local council level. And then we have a wonderful large team of interviewers, about 140 of them, 20 supervisors and about 15 quality control officers that support this enormous data and whose faces you don't see always. You see our faces, but there's a large team behind this data. So thank you so much. This is just a pictorial representation of how the structure is, the technical team within Uganda, and the support I've already introduced, JAPAIGO in the country and in Baltimore, and the Johns Hopkins University in Baltimore, and the technical advisory group that guides us as we provide the technical support in terms of questionnaire design, support to add what components are needed, and then the central team here, and a large team of research assistants here whose photos can't fit here, and the supervisors, but very large team that conducts these surveys. This is our technical advisory group led by Dr. Joseph Musenguzi, as we introduced. The three of us provide secretariat, Mr. Pascal Linga from Japaigo, and then the rest of the partners, some of whom, all of them are here today. Dr. John Sekamate, I saw him, Professor Roda Wanyenze online, Dr. Charles Oralo, Rosalind Achola, Miss, and then Dr. Richard Mugahi, the chair today. We also, this technical advisor group co-ops technical members from the Bureau of Statistics. We have Mr. Mwonge, we have Madame Helen, who were in the last technical advisory group. So the objectives of the survey, we always do this, we've been doing this annually. So we do measure and monitor key family planning indicators on an annual basis. And we also do client satisfaction surveys at the exit of the facilities, which provide the services to the enumeration areas that we go to. And also we monitor family planning commodity stocks, stock in, stock out, availability at the service delivery points, both the public and the private. Today we shall be presenting results mainly from the public sector on that. So in terms of design, the 2021 survey design and its implementation, we went back to 122 enumeration areas. If those who were here last year, and we remember we had 122 enumeration areas, if you do remember, we have added 19 enumeration areas specifically financed by the Children's Investment Fund Foundation, and these are sampled by the Uganda Bureau of Statistics, and that is the big technical support we have from the Uganda Bureau of Statistics to conduct this together. And within there, we sample 35 households, and then we do surveys with women who are eligible 15 to 49 years in those households. And I said we go to the different service delivery points that serve the enumeration areas where PMA goes at the national level. So this SDP sample may be nationally representative, but it's tagged to the enumeration areas where we collect the data from. We do sample randomly 3 in an enumeration area for the private facilities. If they are less than 3, we do all. If they are 3 and less, we do all. If they are more than 3, we sample only 3. But we do all the public facilities that serve those enumeration areas up to the regional referral hospital through the referral system, guided by the district health officers in the districts. And we do conduct client exit interviews in the facilities that serve the enumeration areas who serve 3 or more clients in a single day. We do surveys on 2 consecutive days for all the women that turn up at the facilities if they consent to be surveyed. This year we want to show you a pictorial or a map geographical representation of where our 141 enumeration areas are. These are GPS coordinates of households in the enumeration areas. So the bubbles may be more than 141, although we show that this is 141 enumeration areas. Those bubbles are households in the enumeration areas. So they will be larger depending on where you are in terms of number of enumeration areas. So you see that they are spread out across the country, and Kampala has so many there because Kampala is treated as a region on its own. So that's why you see a lot of concentration of enumeration areas there, but it's similar to other regions when we break them out of the 15 sub-regions in the country. Again, this is done by the Uganda Bureau of Statistics, and we are so grateful for that. These are our survey response rates that we had this time around. We've always had very high response rates, above 96%. Today we have about 96% for the household and the women in survey, and we have about 93% for the service delivery point survey. This has dropped a little bit from about 96 that it was last year, maybe a little bit of fatigue, understandably, but that's what we have now. So, ladies and gentlemen, what are the main findings from this survey? I'll start with a key indicator. Over the last few years, we've been presenting results for the CPR, or the contraceptive prevalence rate for married women, the proportion of married women currently using a method of family planning. This year, I want to present 2 indicators. One, for all women. That's a more conservative indicator. It includes all women, married, unmarried, sexual active or not. So it's a more conservative indicator. The reason we are tracking this out this year is because when you look at the costed implementation plan 2, the focus is on all women. So the indicator is for all women. We don't want to leave anyone behind. You heard Professor Roda speaking about equity. You don't want to leave anyone behind, so we don't want to focus on married women alone because they all have their needs. So today we want to present to you the CPR for all women, the proportion or percentage of women who are using a method of family planning who are aged between 15 to 49. And the CPR in this survey is 40%. So 40% of all women are using a method of family planning. And 34% are using a modern method of family planning at the time when we did this survey in September, between September and November of last year. And the traditional methods are standing at 5.9%. And when you see, we've just picked out only 4 survey rounds. We have so many survey rounds before, but we picked the most recent 4. And you see the trend that we've been rising for all women from 34.7 to 40%. We've not been presenting in the dissemination here, but we've had all this data in the background before. So that is the all methods contraceptive prevalence rate for all women, 40%, and 34% for modern methods of family planning. So, breaking this a little bit further down, we've seen, of course, the 34% for all for MCPR or modern. MCPR is modern contraceptive prevalence rate, and then the 5.9 for traditional. Total together form your 40%. But we have a proportion of women, of all women, who in the survey, when we ask questions about whether they want to have a child soon, within the next 2 years, they say no to that question. But then when we ask if they are using anything to avoid getting pregnant, they say no. So those women, together with those who are currently pregnant, but when we ask if the last pregnancy they are carrying, the pregnancy they are carrying was intended, they tell us it was unintended. So if you have an unintended pregnancy currently that you're carrying, and all you are not using any, and all you don't want to have a child within the next 2 years, but you're not using any method of family planning, those two combined together form what we call the unmet need. So this is technically computed on our side, but based on those questions and a series of qualifications for you to come to this. So 15.3% of all women in this country, 15 to 49, have an unmet need for family planning. If we use, and then, okay, let me first explain this. Then we have 44.8% who have fertility desires. They are intending to have a child within the next 2 years, or they are currently pregnant by choice. So some of the ones in the red are currently pregnant, but unintended. But the ones here in the 44.8, some are pregnant by choice, or they want to have a child within the next 2 years. So those ones have fertility desires. So we don't expect them to be using family planning. So if they are not using, it is okay. Because if they get a child, that child will not be, unintended, unwanted, because they are, within their window, very recent window. So, near future window, sorry. So those are fertility desires. They are still high. We don't want to put a number, a percentage to how many women should have fertility desires at any one point. But of course, when you have such a large number, it means we shouldn't be surprised that we are adding on 1.7, 1.8 million births a year, because we have so many women who are intending to have a child within the next 2 years. Now, some of them may have 1, 2, 3, 4 children. They are intending to have a 4th. Some of them may have 8. They are intending to have a 9th, willingly. So this is a matter of ideation, and Dr. Sekamate loves this ideation, I know. So if I want to take you through a little bit of the stages of change model, I think as implementing partners, we want to focus, the lowest hanging fruits are those who have an unmet need. If you focus on the stages of change, these have some sort of contemplation. Probably they are easy to attract to become users. There are these who have fertility desires. Some of them are pre-contemplators. I have 8 children, I'm focusing on the 9th, I have no problem with it. When you ask me, do you want to have a 9th child? I say yes, and I'm okay. So you're not going to drag me to using, but then the information you provide probably will move me from pre-contemplation to contemplation. So you can move women from the fertility desires to unmet need. That is probably the first stop. Some of them will jump directly to use. That is a winner if we do that. But that is hard. You probably move them to contemplation to think, maybe I should use, then focus on what should I use, where should I get it. And that's where we come in to give as much information as possible. Move them from pre-contemplation to contemplation, and then ultimately to action, and continuation of the behavior, which will be the MCPR. Of course, at any one point, we have to have women who want to have a child within the next 2 years. So we don't want to cut this down to zero. Of course, it doesn't happen. So that's, I think, one thing we can focus on as IPs, where the low-hanging fruits are. You don't want any red, but also you want to move more women, to MCPR. Now, the other indicator, sorry, the titles are hidden for people inside here, but I can remember them for you. These are trends in use of family planning, or the methods of family planning for married women. The slide that we had before, this one, is focusing on all women. Now we go to the one that is focusing on married women specifically. So this is, and let me just focus on the current survey. These are trends, again, from 2018 to the current 2021, September to November. So the current contraceptive prevalence rate for all women is at 50%, 50.2%. Don't confuse this with the 50 that we had in the early CIP 1, because that was 50 for modern, right? This is 50 for all methods. So the modern is still at 42.7. We have not even hit our 2020 indicator yet, which was 50 for modern, for married women. So this is at 42.7%. 50 is the green, the biggest bar, and then the pink is 42.7, and then the lavender is 7.4, which is the traditional methods. So these traditional and combined with the modern form all methods contraceptive prevalence rate. And you can see the trends, as Dr. Olaro mentioned. We are moving upwards. Actually, this year, we see a significant jump. What you see here are error bars or confidence intervals. So you can see that over time, we've had, in some surveys, although we presented an indicator that was slightly higher than the year before, it wasn't significantly different. But today, we are presenting a figure that is significantly different from, for example, from 2019 onward. So we've had a real, true increase. We had COVID. We've been in COVID. This survey has been conducted after a series of restrictions and lockdowns. But remember, you all partners and Minister of Health, you had adaptations. Maybe the adaptations have worked. Dr. Olaro mentioned, we need to focus on, I think Dr. Mugahi as well, we need to focus on what works. So what is it that has worked this time around? Those adaptations, maybe we need to take them forward. Maybe the services were hit, but maybe people were at home, and so they had the contemplation to think, I am home more. Maybe there's more frequent sex. So maybe they thought about use, which they did not have to think about before. So some of these could be our explanations. We don't know. We present this to you, but you have some thoughts behind the data if you want to discuss it. So this is what we probably think, that maybe that's the jump that we are seeing from 44.8 to 50.2 for all methods contraceptive prevalence rate for married women. And remember, in the morning, in the Dean's remarks, she mentioned that we don't want to leave anyone behind. And so we've had to break this down a little bit, but not too much, because we don't want to have so many, a slide congestion here. So we only focused on residence and education. Again, this is modern contraceptive. This one now is focusing on only modern among women in the rural and urban, and then those with different variations of education. And we see that the p-values you see up there, 0.034 on the residence, shows that there is a significant difference between the urban and the rural. So the urban women at 47.9% for modern methods among married women in the urban areas is different from 41.5 in the rural areas. So we still have equity issues between the urban and the rural, because ideally people should be on the same footing if we are focusing on the ideal world. But we see that there are challenges in the rural areas. Even the urban still have challenges. We have urban poor and all that who are bringing down that indicator, but we need to focus on them as well. For the education, we have some sort of dose response. The higher you go with education, the better. You can see that there are significant differences between those in secondary and then those in primary. So when you go to secondary and over, and the Dean mentioned about education, not forgetting education, it has an impact, and you can see the impact really. And you see that, higher dose response. The confidence intervals are wider at the top university and tertiary because we have a smaller sample size there. There are very few women in this country that have tertiary and university education, which is, of course, not a very good thing. Okay, so then we go to the breaking down. We call this the method mix. The method mix is we get all the women who are currently using a method, this time modern methods of family planning, and then we just distribute, the methods around and see what are they using. So how is the distribution? Okay, I think the ideal should have been equal, but it doesn't happen. That's the perfect world. So what we see is that injectables, and that is IM, I think that's green, where you see inject IM, that is intramuscular, DMPA, and then injectable SC, which is the subcutaneous, that is cyanopress. So those combined form about 40, so these ones are still the most used method. The injectables still dominate our method mix for married women. And then we have the distribution we have the implants, which are rising. They have been rising fast over the last surveys. This year, actually, we didn't have a jump, that much for implants, but they remained, steadily up there as the second most used method. And then we know that the long-acting methods are more effective. So we want to probably, have many more women move to that level. And then maybe here what you see is that the IUD has not been growing. The IUD has not been growing. It is stagnant over the last about, I think, 4 surveys. We've been seeing, we had, I think, 3 at some point, then moved to 4, then 5, then we've been stagnating at 5, I think, last 2 surveys. So we don't know what's going on there, and we know how effective the IUD is. So maybe something to think about there. Okay, then quickly, about to complete my part, these are trends in demand, total demand, and demand satisfied. Again, this is focusing on married women, and you can focus on the gold part there, which is the last survey, the current survey, September to November 2021, the different colored one. And what we have as total demand is the combination of those who have an unmet need plus those who have a met need. The met need is those who are using a method of family planning. So you have 20.9 in the last column, plus 50.2, which give you 71.1. That is our total demand. I think you can see over time that the total demand is not increasing very well from the last survey. It has increased a bit, but probably not rising very fast. But when it rises, we need to keep it rising with methods of family planning, not unmet need, because it could also rise, but it could be a contribution of unmet need. Luckily, we see that unmet need is dropping, and you see it has dropped from 23.8 from the last survey, from 2020 to the current 20.9. So we're doing something, at least I think as IPs, you're doing something, and Ministry of Health. And what is of that demand, the 71%? What demand is satisfied by modern methods? So the demand satisfied by modern methods is basically the modern contraceptive prevalence rate, which is 42.7, the second last row, and in the last column, 42.7 divided by 71.1, that will give you about 60%. So 60% of our demand is satisfied by modern methods. One thing you need to note here is the demand that is satisfied by modern methods has actually moved from 54 to 60%. And I think wonderful. It means the MCPR has actually improved, and that's what we saw. So we are doing, at least we are getting somewhere to that level, but we want this to be, of course, much higher than that. And then, now I dive into the quality. And this is a nagging indicator, ladies and gentlemen, over time. The quality of services is still wanting, even before I present the results, and you can see it already. So this is what we call the Method Information Index Plus. It's a combination of 4 questions. One of the questions is we ask among those who are current users. Now, these are women we have won over already. So we have them. They are converted. They are using. But what are we giving them? What you give me when you have won me over determines whether I stay or I leave. It determines whether I bring somebody else or I don't. If you are served badly in a restaurant, I don't think you recommend it. If you're served well, you keep going back, but you may go back with a friend. So how about we look at family planning service like this? This is the quality we are providing. So these are the 4 questions. Women who are told about side effects among current users, we asked them, the last time you obtained this method you're using, were you told about side effects? Were you told, if you are told about side effects, were you told what to do about those side effects in case they happened? Were you told about availability of other methods other than the one that you've taken? Were you told about the possibility of switching if the method is switchable, or if it's permanent, were you told also about that? So we see that only 43.8% of women who are currently using a method of family planning were actually told about all the 4 questions. Only 43.8. Last year we had about 42, 0.2, I think. It's not rising, really. This is a stagnating indicator. We want this to be up there 100%. And you see that the problem is that cutting across equity issues, leaving no one behind, everyone is behind this time around. Okay, you can see urban and rural, same problems. Age groups, maybe adolescents are worse off, but also, common problems even among older women. So we are breaking this down just for you to see. If you are Minister of Health, if you are an implementing partner, any one of us, all of us here, where are we doing worst? Because when we combine the indicator, we combine an index combines all the 4 questions. Now we want to break it down. Maybe we are doing well on some of them. We're actually doing bad everywhere. But we're doing worse where it matters the most. Side effects. Women are not being told about the potential side effects of the method. They are not being told what to do in case they experience those side effects. We don't have the results, we don't present the results today here, but we have the data which shows among the non-users now, when you ask them, why are you not using a method? Fear of side effects, method-related concerns. Then you go to the users and you ask them, were you told about side effects? No. So if I wasn't told about side effects, I experience them, I go to my friend is not a user, she fears side effects. I wasn't told, I've experienced them, what am I going to tell her? So am I a change agent? No. So I think we need to focus on that and make sure everyone is told about potential side effects and what to do in case they experience those side effects. And that is a challenge. And usually I tell this because we get calls from the field, because our numbers and the consent forms on the surveys. But interestingly, many of the phone calls we get are not from women who participate in the survey, but from their friends who are looking for support. And last week, I think Prof. Makum, it was last week, we got a call from Bulisa. Of course, sometimes people call you and I'm struggling with language and I look for somebody who speaks the language. You don't have anyone. Then can you speak some English? Then we speak. And then she told me, I stopped using the injectable in December. That's when it was supposed to expire, I think December 12th. She called and she said, I have not seen my menses. I have not returned to my menses and I am worried. I don't know if I'm pregnant or not, but I stopped using it to get what? To get pregnant. And now I'm worried. And she was at a facility somewhere in Bulisa. She wasn't, being attended to yet. She was, I think, in a line. But she called this number and they said, they told me you're one of the health workers. Unfortunately, when they see the consent form numbers, they think you're a health worker. So they call. And we thought with Prof. Makumbi, maybe we need to have a functional call centers that people can actually call into, and these numbers are publicized, and people really pick them, and they're toll free. Because this is somebody who was calling using an MTN line, calling my Airtel line. They are investing time and money into trying to get the quality that they need. So she's not aware that maybe these are delayed menses and it's normal, because they were not told when they were receiving the method. So this is where we need to do quite some work. So I want to stop it here and then hand over to Professor Makumbi to take you through the next part of the presentation. Thank you so much for listening.
Yes, so thank you very much, Simon. I wish this could go a bit lower so that I can be like you. But I hope I can hang in there. So I'm going to do the last part of this story. I hope I can maintain the narrative. But we have been touched by many stories coming from the communities. And actually one time somebody called me because they had got some side effects. I didn't know how to handle them suddenly. But I was able to engage our colleague Sarah. She has a clinical nursing background. This was at night at 9. And this was a desperate woman in Ibu, in Eastern, Buked, something like that. I said, okay, we are putting our lives in line, but good enough, we don't fake. We are not medical doctors. We look for the clinical persons, and we only tell them, yes, we've got the information, let us take it, the talk, and appropriately handle this. Yeah, but these real life stories are not like, oh my goodness. So people are following up, and they are trying to look for help. But given those stories, there are issues of intentions to use, as Simon has indicated. Ideation, people with unmet need. When we go out, we ask women whether they intend to use contraceptive methods. This time around, we asked people, women, who are non-users at the time, whether they intend to use contraceptives in the next 12 months. Literature has shown, including what we have done, that actually intentions to use is a good predictor of who will subsequently use. So when we asked, for every 100 women we asked, only 20% said they intend to use. Maybe we need to work around improving. If intention to use is a predictor, we may need to work around there and also address the issue of those who are in the fertility desires. Maybe they may want to change for as long as they have information. Mr. Mwonga, when he was here, he's indicated to you that we have changed the design of this, how we evaluate and generate evidence. And some of the things we have started to do is we have been able to identify women in 2020, the last survey of 2020. We asked them how many intended to use modern contraceptives in the next year. And some of us told us they did not intend to use in the following year. So when we came back in 2021, those who say they intended to use in the future, 46% end up using modern method. Of those who say they did not intend to use, 1 year later, 20% had indicated. So intentions change and practice. So this means we need to work on those who say they intend to use and avail maybe services and also continue engaging them. Maybe shall move from 46% to maybe 90%. There are barriers and challenges which do not make those who intended to use. But also free to withdraw and change and say this time around I don't want to use. So, but we should be able to tap into that. But what is also very striking, those who say they do not intend to use, 20% use subsequently 12 months. Which means if somebody says they don't intend to use, just don't give up. Continue engaging and availing appropriate messages, and they can change their views given the circumstances, as we may have seen during the COVID period. The other interesting piece that we have here, this is, so we also went ahead, this has been covered. Women with the most recent pregnancies, what proportion had unintended? We looked at women who had had their last birth recently or who are currently pregnant. Then you ask them, wow, how many of you intended to have these pregnancies? 46% of those who are currently pregnant or who had a last recent birth in the past 5 years, 46% said we did not intend to have that pregnancy. In a quick way of summarizing this and communicating to my village person or somebody who is not very conversant with the numbers, I can say for every 2 women who are pregnant, 1 of them did not intend. That's not very small. And we went ahead and say, what does that mean? Of those, how many had actually wished to not ever have any child? And how many actually wished to have children, but not at the time they did? Of the 46%, we subtracted and found that 13% of them did not actually want to have children anymore. So for those 33% who wanted to have children later on, you may say, okay, mistimed, whatever you want to call it, but the 13% who did not have any more, they had an additional family member. What is happening out there in order to look at the quality of care for the 13%? But what is also very striking, I'm a teacher and I'm good at pointing. The first batch is for, when you look at the 15, when you look at the 15 to 19-year-olds, there's no difference in unintended pregnancies between the rural and urban. The pink and the purple have the same level almost. So they think of saying, oh, the problem is the urban only, rather rural. No, we need to also work on the rural and the urban together. Are those being affected by the urban poor? We don't know. So more research we need to dig in and understand. But of course, this biggest problem between rural and urban, the difference in terms of unintended pregnancy is more common in the green one, the rural, when you look at the older women, 35 years and above. All these are lessons we need to think, the strategies. It's not a one-size-fits every age. We need to know which ages we are dealing with. Recently, I think the past 2-3 years, we have been working with Ministry of Health is leading the National Self-Care Guidelines. That's a big approach of seeing how can we enhance family planning services, and then that will roll into other services. So there's a component that focused on DMPA sub-Q or injectable sub-Q. Remember they had injectable IM and sub-Q and self-injection. So I'm going to present data which may provide us with a clear understanding of how self-care through self-injection with a focus on DMPA sub-Q or injections